Welcome to this explainer. Today, we're diving into one of the absolute most foundational, life-saving protocols in all of obstetrics and neonatology. Whether you're a seasoned medical professional or a medical student just starting out, mastering the delivery room really means mastering a newborn's first moments of life. And to do that, you absolutely must understand our topic for today, the Apgar score.
Just think about the intensely high-stakes environment of a delivery room for a second. A baby is born, and suddenly, boom, the clock starts ticking. You don't have minutes to run complex labs before acting. You literally have seconds. In those fleeting moments, you have to make a rapid, precise decision that can accurately predict a newborn's survival and long-term neurological outcomes. That is the sheer genius of the Apgar score. It distills all of that immense complexity into an assessment that takes merely seconds.
Okay, let's dive into our clinical playbook today. We'll be looking at the clinical significance of the Apgar score, the 5 crucial criteria, the exact timing required, results analysis and tactics, some real-world practice scenarios, and finally, the score's modern limitations.
Let's start with Section 1, the clinical significance of the Apgar score.
So, why is this specific scoring method relied upon in literally every delivery room across the globe? Well, the real power of the Apgar score lies in its incredible speed and accessibility. You don't need any complex, heavy machinery. All you need are your eyes, your ears, your hands, and a stethoscope. It gives you immediate clinical direction, telling you exactly how the baby handled the stress of birth at minute 1 and how they're adapting to the outside world at minute 5. Plus, while it's definitely not the only factor, persistently low scores are a massive flashing warning sign for severe neurological risks down the line, like cerebral palsy.
Moving right along to Section 2, the 5 crucial criteria of APGR.
Now, what's really interesting here is how this elegant system was turned into a brilliant mnemonic by pediatrician Joseph Butterfield back in 1963, basically to honor its creator, Dr. Virginia Apgar. It flawlessly breaks down complex neonatal physiology into a simple 0 to 10 scoring system. A is for appearance or skin color. P is for pulse, the heart rate. G stands for grimace, which tests reflexes and irritability. The second A is for activity, assessing muscle tone, and finally R is for respiration, evaluating breathing effort. For every single one of these 5 signs, you just assign a score of 0, 1, or 2. Add them all up, and you've got your total out of 10.
Let's take a closer look at appearance. A totally pale or blue baby gets a 0, which signals severe hypoxia. A completely pink baby gets a 2. But here's the thing, most babies actually get a 1, and that's due to a condition called acrocyanosis. This is where the body is pink, but the hands and feet are blue. Don't panic when you see this, it's a completely normal physiological response. The newborn is literally just protecting its vital organs from the cold delivery room air by constricting its peripheral blood vessels.
Next up is pulse, arguably the single most critical component here. 0 means no heartbeat. 1 is under 100 beats per minute, which is a major red flag for hypoxia. 2 is over 100 beats per minute, and I want to share a favorite hack among medical professionals for this. Rather than spending a full 60 seconds counting, just use your stethoscope or palpate the base of the umbilical cord for exactly 6 seconds. Count the beats, multiply by 10, and boom, you instantly have your heart rate.
Moving down to respiration, we're looking for a strong, lusty cry to give a score of 2. A weak, irregular gasp gets a 1. And, keep in mind, gasping is not normal breathing. It actually means the brain is starving for oxygen. But a 0? A 0 means apnea. This is the complete absence of breathing, indicating a paralyzed respiratory center that is a red alert emergency situation that requires immediate positive pressure ventilation to save that newborn's life.
Section 3. Time. Specifically, the crucial 1st and 5th minutes. Knowing the criteria is really only half the battle. You have to know exactly when to evaluate them because the timeline is incredibly strict. The very first assessment happens at precisely 60 seconds after birth. This evaluates how the baby handled the sheer stress of labor. The second assessment is at exactly 5 minutes, telling us how well the baby is adapting to the outside environment or how they're responding to our resuscitation efforts. And if that score at 5 minutes is below a 7, we don't just stop. We continue extended tracking every 5 minutes, so at 10, 15, and 20 minutes, to guide major therapeutic interventions like brain cooling.
But listen, I need you to remember one absolutely non-negotiable rule. We do not wait for the first minute to start resuscitation. The Apgar timer is a guide, it's not a barrier. If a baby is born limp, completely blue, not breathing, or with a heart rate under 100, you do not just stand there holding a stopwatch for 60 seconds. No way. You begin life-saving interventions within 15 to 30 seconds. The Apgar score is simply recorded in parallel with your actions.
Section 4. Results, Analysis, and Tactics. So, once you have your numbers, what do you actually do with them? Well, we group the total scores into 3 actionable tiers. A score of 7 to 10 means the baby is in great shape. No special intervention is needed, just dry the baby, keep them warm, and place them skin to skin with the mother. And remember, a perfect 10 is super rare because of that normal acrocyanosis we talked about earlier. Now, a score of 4 to 6 indicates moderate depression. These babies need immediate tactical support. You need to clear their airways, stimulate them by rubbing their back, and provide supplemental oxygen if their breathing remains shallow.
But if that score is between 0 and 3, you have a severe, life-threatening emergency right there in your hands. You've hit the golden minute. You have to immediately trigger the neonatal resuscitation program algorithm. Step 1. Start positive pressure ventilation with oxygen using an ambu bag. Step 2. If the heart rate stays below 60 beats per minute despite that ventilation, you immediately start chest compressions. Step 3 involves intubation and administering adrenaline. This is a sequential, incredibly high-stakes action plan that literally has to happen instantly.
Section 5. Practice. Let's analyze some real-world clinical scenarios.
All right, you know the theory, you know the tactics. Let's put you right in the delivery room to test your new knowledge. Here's scenario 1. A baby is born full term at 39 weeks. At 1 minute, the baby has a strong cry. They're actively moving their limbs. You check the pulse, and the heart rate is 140 beats per minute. The baby's body is pink, but their hands and feet are blue. Take a second to think about it. What is the Apgar score for this baby?
Got it? The answer is 9. Let's just do the quick math on that. A strong cry gives a 2 for respiration and a 2 for grimace. Active movement is a 2 for activity. A heart rate of 140 gets a 2 for pulse. The only deduction here is 1 point for appearance because of those blue extremities, which, as we know, is just normal acrocyanosis. So this is a perfectly healthy, thriving baby.
Okay, now for a much tougher one. Scenario 2. It's an emergency C-section at 36 weeks due to maternal eclampsia. At 1 minute, the baby is apneic, not breathing at all. The body is completely cyanotic, so entirely blue. Heart rate is 80 beats per minute. The baby is totally limp and only gives a slight grimace when you suction the airway. So what is the score, and much more importantly, what is your immediate tactic?
So, the crucial point is calculating this incredibly fast. Appearance is 0. Pulse is 1, because it's under 100. Grimace is 1. Activity is 0. And respiration is 0. That's a total score of 2. You've got severe asphyxia. Your tactic? Instantly abandon observation, jump straight to the resuscitation table, and initiate positive pressure ventilation with an ambu bag.
Section 6. Limitations of the scale and the modern context. As absolutely brilliant as the Apgar score is, we really have to remember that no single clinical tool is perfect. You've got to understand the context behind the numbers. For instance, premature babies naturally have lower muscle mass and underdeveloped respiratory centers, which means their score might sit at a 5 or 6 even if they aren't actually suffering from oxygen starvation. Likewise, if the mother was given heavy pain medication like opiates during labor, well, those drugs cross the placenta and depress the baby's reflexes. Congenital anomalies can also completely mimic asphyxia. And finally, there's always an element of physician subjectivity, right? One doctor's pink might honestly be another doctor's pale.
And because of that inherent subjectivity, modern medical standards require backup. Today, the rapid visual screening of the Apgar score is paired with a strictly objective laboratory test, the umbilical cord blood gas analysis. If an Apgar score remains below 7 at the 5-minute mark, doctors will draw blood directly from the umbilical cord. They're looking for a pH below 7.0 and a base deficit greater than 12. This is what legally and clinically proves the presence of true metabolic asphyxia. And that's crucial, because it protects both the patient's future care plan and the medical staff from unwarranted legal liability if complications like cerebral palsy happen to arise later on.
The Apgar score is far more than just jotting down numbers on a medical chart. It's a dynamic, living assessment that bridges the gap between observation and life-saving action. It is quite literally the foundation of neonatal care. So the next time you find yourself standing in a delivery room, you really have to ask yourself, are you ready to look beyond the numbers and make every single golden second count? Thanks for joining me on this explainer, and keep learning.